Good afternoon, and thanks for joining us for today's breast cancer question and answer webinar. I'm joined by Sharon Merritt. Thank you again for joining me today. The topic is triple negative breast cancer. It's a topic that was chosen by people that communicate with you about questions that they wanted to ask and have answers for about triple negative breast cancer. So that's today's topic. I want to start by disclosing that I'm not a medical oncologist. I'm a surgeon, but my goal is to provide you with information to help you understand the diagnosis better, and also to give you the tools to communicate with your other providers about it, to communicate with your medical oncologists, your surgeons, your naturopath, so that in the dialogue, you have a better understanding of the diagnosis that you're discussing and of the treatment recommendations that they're making for you. This, as you know, is a series of webinars that we've been doing together. They've been every other month. So the next one would be in mid-October. We'll release a date later, and we'll solicit a topic from the audience to figure out what we'll talk about next time. Thanks for making yourself available again for this. Ready to get started?
Okay. What is triple negative breast cancer?
Okay, so the first question, triple negative breast cancer. Triple negative breast cancer is a type of breast cancer that lacks three important proteins that help define tumor behavior, but that also serve as targets for treatment. Those three proteins are called estrogen receptor, progesterone receptor, and HER2/neu receptors. These receptors are proteins either within or on the surface of a cell, a cancer cell. They're also present on normal cells, but particularly on cancer cells, their presence or absence not only helps us predict the behavior, but also tells us how we can treat them. For example, an estrogen receptor positive cancer has receptors that you can use to target the treatment. So we give an anti-estrogen medication for those. A HER2/neu positive cancer has a protein called HER2/neu on the cell membrane, a cell surface, that can be used to target treatments as well. And in addition, we know by virtue of it being estrogen receptor positive that it generally has a more favorable prognosis, and by virtue of it being hormone receptor negative, that it might have a worse prognosis. In the case of triple negative breast cancers, they lack the estrogen receptor protein, they lack the progesterone receptor protein, they also lack the HER2/neu receptor protein. And by virtue of that condition, they can't be targeted with any of those medications that target estrogen receptors or HER2/neu. And they also, unfortunately, have, on average, a worse prognosis, because those are the characteristics of tumors that tend to be more aggressive.
I just want to clarify something back. Could like the receptors, the estrogen and all that, and HER2, and the fact that like all the cells have it, but the fact is it's when they go rogue that it's an issue.
Right. I mean,
I just want to clarify that.
Yes, there are, many normal cells have these receptors. That's why when you give a drug, there's sometimes side effects that affect normal cells. But breast cancer cells tend to have a higher concentration of it. They also tend to be less able to repair themselves from injury. So although the normal cells get injured a little bit, they have better ability to repair. The cancer cells, hopefully, have less ability to repair. So when we target them with an anti-estrogen drug or HER2/neu receptor targeting drug, they get injured but don't recover as well.
How common is TNBC?
TNBC meaning triple
Triple
negative breast
cancer.
cancer, not your latest news channel.
No.
TNBC, triple negative breast cancer, is present in about 15 to 20% of breast cancers diagnosed today. That's in the general population. So if you take 100 women diagnosed with breast cancer, about 15% to 20%. But there are also some patterns that we recognize where triple negative is more common. And one example is in younger women, it's more common. It's more common in African Americans. It's more common in Hispanic women. It's more common in premenopausal women, meaning younger. It's more common in settings of when there's a history of obesity or high BMI. And so statistically speaking, in those populations, you will see it more often. But if you think of the entire population, the vast majority of people will have hormone receptor positive tumors. The minority, 15 to 20%, will have triple negative breast cancer.
That just answered the next question.
Perfect.
Is triple negative breast cancer impacted using sugar in the diet?
So it's a kind of complicated question and an answer as well. But the point is that when we digest sugar, you know about insulin, and,
Right.
and our body tries to take the sugar and either use it to make energy or store it. There are hormones that are released to facilitate the storage of that estrogen. And one of those hormones is called insulin-like growth factor. Insulin-like growth factor. Insulin-like growth factor is a protein that cancer cells have in greater quantity.
Mhm.
It's kind of a survival advantage that they have, which means that they're much more effective at grabbing sugar to grow, more effective than your normal cells. So the relationship between, sugars and cancer, to a large extent, has to do with this insulin growth factor and the ability of cancer cells to advantage themselves by grabbing sugar faster and more effectively. The things that drive up the insulin fastest, like processed sugars,
Mhm.
fruit juices, sodas with sugar, simple sugars, they not only drive up your insulin level faster, but they also raise the insulin like growth factor level faster,
Which feeds the cancer.
which feeds the cancer. So generally, things that are complex carbs, natural sugars, those things generally be better. Kind of like the type of diet that a diabetic would have, where they're trying to regulate how fast their sugar rises. That is the kind of diet that would probably be the one that's most useful for cancer risk reduction, because it doesn't fuel the estrogen, the insulin rise, or the rise in insulin-like growth factor.
Or cut out sugar altogether.
Well, it's difficult to cut it out altogether, but you can certainly minimize it.
Well, at least processed sugar.
Yes, processed sugars. Yes, that's the
Not fruit sugars.
exactly.
Is triple negative breast cancer impacted use? Oh, never mind. Are there any
So
blood?
the answer is all cancers are impacted by
Sugar,
that
yeah.
fact. The triple negative is not uniquely so.
Right.
It is a risk factor for both for the incidence and recurrence of both hormone receptor positive breast cancers as well as hormone receptor negative or triple negative breast cancers.
Are there any blood tests for triple negative breast cancer?
So there's not a test per se, but there's something that I wanted to mention in response to this question, that, as I mentioned earlier, there's some populations that have a higher risk of triple negative breast cancer. So for any any patient with a diagnosis of triple negative breast cancer, we must consider whether or not they're a mutation carrier, a BRCA1 or BRCA2 carrier, because the incidence of triple negative breast cancer in BRCA carriers, BRCA1 and BRCA2, is about 30%.
Oh, wow.
So it's about double the rate in non-mutation carriers. So whenever we see someone with a BRCA1 or BRCA2 mutation, it's appropriate to do genetic testing if there's not another reason to do it. At the very least, the diagnosis of triple negative breast cancer itself is a sufficient reason to recommend genetic testing, because not only it does not, knowing that not only advises you on the patient's general risk for cancer, and that might be important for their family as well, since it's hereditary, but also there are special drugs that are given for mutation-related triple negative breast cancer. So knowing that allows you to adapt your treatment for that diagnosis. And I think we'll talk about that. again,
Yeah, I think
perhaps.
there's a question about that. What is the role of checkpoint inhibitors in TNBC?
Yeah, so a little backstory. So when you have, say, a cold or any kind of infection, there's a normal response where your immune system gets ramped up to attack the virus or attack the bacteria. You also know that at some point it turns off, and it
Right.
stops, and because otherwise you
It's over,
continue to
yeah.
be inflamed. But the natural process is for the the inflammation to happen, and then there's some triggers that says that, okay, the infection's over, you can go back to rest now. And so there are processes that control that, and those processes that turn off the immune response is called the checkpoint. That is, you're inflamed, but now you've reached a point that that your work is done. You've reached a checkpoint, go back to being rest. So the reason that I'm giving you this story is that this turn on, turn off phenomenon in the immune system is important just for normal immune function. The turn off, the checkpoint, is something that we do because we don't want to have persistent inflammation. But the ability to turn off inflammation is not something that only exists in healthy cells. It also is an adaptive thing that cancer cells have developed. That some cancer cells have said, okay, if we make the checkpoint, then we can turn off the immune system so the immune system doesn't recognize us. So there is this thing called a PD-L1, which is a protein that some cancer cells release that tells your immune cells to turn off. And so you might actually have an attack, your immune system might actually be attacking the cancer, but they're not effectively penetrating the cancer because they're facing this wall of proteins that's telling them to stay at bay, go back to rest. So checkpoint inhibitors are important because we now have the ability to block the cancer cells' production of this protein. The drugs, which are called checkpoint inhibitors, inhibit the protein that your cancer cells might make to prevent your immune system from responding to the cancer. Hopefully that wasn't too complicated. So
basically, you have a drug that can fight the cancer and keep it from stopping the immune system from eating it.
that's very simply put. Yes, thank you for that. And it's the inhibitor is the drug that actually stops the cancer cells' proteins. And so it's in the category of immunotherapy, but it's a very specific approach. Now, most cancers don't have a high number of or high rate of those checkpoint inhibitors, the PD-L1. In general, triple negative cancers are more likely to have PD-L1 overexpression. By overexpression, it's just a few percent. Most cancers have none, but the cancers that do have that are making those proteins to inhibit the immune system, they're cancers that are now suitable for certain sort of drugs, and those drugs are checkpoint inhibitors. And one of those drugs now is Keytruda, for example, which is done to make your body more effectively respond to a cancer cell.
What is the role of immunotherapy in TNBC?
So immunotherapy is, in fact, Keytruda is a type of immunotherapy, and it basically speaks to the understanding that in the evolution of a cancer, there is also immune response that parallels it. Sometimes immune response is effective at keeping the cancer from growing. Sometimes some cancers have very little immune response because they're able to hide very well from the immune system, and others have immune response, but they're able to keep it at bay because they're producing PD-L1, which holds the cancer. But it tells us that it's not just a matter of targeting the cancer. Perhaps, and we have ways, and as we do now, of targeting the immune response so that we can more effectively treat the cancer. One very simple form of immunotherapy that we've been using for many years, but most people don't think of it that way, is anti-HER2 therapy. What we give when we give anti-HER2 therapy is an antibody targeted towards the HER2 new receptor that helps your body recognize that HER2 new overexpressing cell as an abnormal cell, and the immune system attacks it. So this works slightly differently in the case of triple negative breast cancer, but we're basically trying to do is regulate that relationship between the immune system and the cancer cell so that the immune system gets the edge and the cancer gets recognized and attacked as a result of it.
The next question is there a role for anti-HER2 therapy in TNBC? And it's interesting, I recently did a coffee talk where one of the researchers was explaining that they're talking about using anti-HER2 therapy or Herceptin as a Trojan horse because all the cells have some HER2 protein. And if they put the chemo in the monoclonal antibody, the cell is more likely to suck it up, and then the chemo gets in there and can fight it better.
Right. So,
but that's all in process now. It's not something that's out yet.
So there are two things. You touched on one. Let me touch on it first, and then I'll address the one that you said. So the most important aspect of that question is that, when I described earlier that we have, ER positive and ER negative cancers, PR positive and PR negative cancers, and HER2 positive and HER2 negative cancers. we are now at the point of reconsidering that simplified classification. And when we say that something is HER2 new negative, it means that it doesn't have a really high amount of HER2.
It still has some.
But it has either some or none. It could be
Okay.
0. We usually the scale is 0, 1, 2, or 3. So if it's 3 plus, that is like threefold amount, if you will, then there's no question that's positive.
Okay.
If it's HER2 positive plus 2, we usually do a confirmatory test like FISH testing to see if it's really high or really not. In most cases, we end up classifying it as really not, or HER2 negative. And so we don't treat them with anti-HER2 therapy. There's also +1, which we generally consider to be negative. You know, we don't need to do FISH testing on that. And HER2 0 means there's just none.
Yeah.
Well, we've learned from a recent clinical trial that people with +1 and +2, even though they're technically negative by the traditional definition, there actually is some HER2 activity in those patients. And so for people that are on triple negative, who've had diagnosed triple negative breast cancer and haven't responded or have a recurrence, you know, some of my colleagues are now retesting them or re-examining their studies, seeing if they're HER2 new negative but +1, or HER2 negative +2, which is maybe kind of positive, and then utilizing a new medication called Enhertu, which was shown to have benefit for those patients. So triple negatives may not be fully triple negatives, they may be triple negative mostly, but if they have a little HER2 activity and they need additional therapy because maybe they didn't respond to the recurred, then Enhertu is another tool available to attack those cancers. Now, there was a second question to that. And it's you mentioned something called the Trojan horse.
The Trojan horse, yeah.
So it's really interesting.
I forget the name. Vanderbilt University, I think, is doing the study.
Yeah, so it's an interesting concept. So the term that refers to it is an antibody drug combination.
Right.
Meaning they attaching an antibody like Herceptin to a drug, and the combination would then attach to any place where the HER2 antibody attaches, HER2 positive cells. And in that attachment, it basically facilitates the
chemo drug or the molecule
entry of the chemo drug. So there are drugs that are now emerging. They're relatively new. There's one on the market now, still in clinical trial, actually. But there'll be more and more antibody drug combinations as a way to more effectively get the drug into the cells that you try to target and spare the effect of the drug on cells that you don't want to target.
And maybe can you use a lower dose of the chemo that way?
You may be able to.
Which would be a lot better.
Yes.
I think you might have done this one. What is an antibody drug conjugate and how does it apply to TNBC?
That's it. I called it antibody drug combination, but conjugate is the same term, and that's the point, that there are emerging therapies for facilitating the delivery of drugs to triple negative cancer cells, and these drug combinations or conjugates are made to way to do so.
What is a K1 number and how do you find out what yours is and what does it mean?
Yeah, it's actually
Ki.
Ki.
Okay, Ki.
Yeah,
I wasn't sure if it was a 1 or an I when she typed it.
So we talked about ER, estrogen receptor, progesterone receptor, HER2 receptor. So those are receptors, and they're pretty much tested on all cancer cells. I mean, they should be tested on all invasive cancers. But there's a fourth thing that's commonly tested called Ki67. It actually isn't.
I know what you're talking about.
Yeah, it isn't a receptor, but it actually is just a calculation. When they look at the cells in the microscope, cells that are in the process of multiplying look different. They're the things that they can identify under the microscope.
Right.
Say that cell is dividing, that cell is dividing, that cell isn't. And so they calculate the percentage of cells dividing over the total number. 10 cells dividing, 100 cells present, your Ki67 is 10%. And so there's a scale, less than 10%, 10 to 20%, 20% and above, where if your Ki67 is low, less than 10%, we consider it to be a more favorable cancer, less in need of chemotherapy, likely less responsive to chemotherapy. If the Ki67 is high, over 20%, it's likely it's one that would be in greater need of chemotherapy. And so we use this as a way to kind of determine the activity level of the cancer. If it's the one that's rapidly multiplying and maybe spreading, or is it one that's kind of quiescent, growing, but growing slowly?
Is mastectomy preferred to partial mastectomy, lumpectomy, and radiotherapy for TNBC, and which has the lower risk of a recurrence?
So this is an interesting topic. So the most important take-home message regarding this question is that for early stage triple negative breast cancer, so tumors under 5 centimeters and no lymph node involvement, the prevailing evidence indicates that a lumpectomy and radiotherapy has better long-term control than simply doing a mastectomy.
Can you do the cryoablation instead of lumpectomy?
Let me come back to the question. And the answer to the question isn't exactly clear, but it is likely due to the fact that radiotherapy, when given, especially when given in a traditional way, given to the mastectomy site, or given to the whole breast, given to the lymph node area, that it probably treats more tissue than simply doing a mastectomy, which leaves skin and some tissue under the skin and tissue over the muscle that could potentially have some tumor cells left. But if all you do is a mastectomy, those tumor cells aren't necessarily controlled. So there have been a number of very large studies, but not randomized trials, looking at the outcome of people with early stage triple negative breast cancer treated with lumpectomy and radiotherapy, and those treated with mastectomy. And all of them show better survival for those treated with breast conservation, lumpectomy, and radiotherapy.
But when you're saying mastectomy, that's not without the radiotherapy.
Right. We're just doing a simple comparison of lumpectomy plus radiotherapy versus mastectomy without radiotherapy. Now, people with node positive disease or more advanced, bigger tumors, even when they get mastectomy, we add radiation for those patients. So, but we're not talking about the patients with advanced. They all get radiotherapy. We're talking about the early stage patients who might think that a mastectomy is better for them. It actually isn't. The data doesn't suggest that. The data suggests that the lumpectomy with traditional radiotherapy is actually more effective long-term. Now, you asked about cryoablation. And so my thoughts about this is that cryoablation simply is a substitute for the lumpectomy. But if you want to get the same long-term results that I've described with breast conservation, it should be cryoablation and traditional radiotherapy.
But it'd be the same thing as a lumpectomy or a cryoablation would be either way.
Right. Followed by
how about as big as like you said, 5 centimeters?
Right. So that, technically treating a 5 centimeter tumor is challenging with cryoablation. It's also challenging with surgery as well. But in general, there's another story to be told about that. But the trial is for T1 and T2 tumors, and T2 goes up to 5 centimeters.
Okay.
So that's what the data support. Now, I suspect that most of those patients in the study were closer to 2 than the 5, because the challenge with 5 is that it's hard to do a lumpectomy on a 5 centimeter tumor and have a cosmetically acceptable breast. So many patients with larger tumors, and certainly almost all patients now with node positive disease, with triple negative breast cancer, have chemotherapy up front. And so that big tumor becomes a smaller tumor, hopefully, and becomes easier to manage with lumpectomy or cryoablation even.
Okay, I was just thinking on the cryoablation side, so you would freeze the size the tumor is now? I know we're getting off a little bit.
Well, but I'll answer your question. So, in general, yes. When you do a lumpectomy after preoperative chemotherapy, the tumor starts this big, tumor hopefully shrinks, and you have the freedom as a surgeon to, and it's actually the standard practice, to remove just the remnant tissue, not the original volume, but whatever looks still to be abnormal, or the clip that was placed at the time of biopsy. Now, the reason that you can do that is that tissue will be sent to a lab. They're going to check to see if there's cancer present. They're going to check to see if the margins are involved. And if the margins are involved, you go back to surgery to take out more tissue likely. With cryoablation, we don't get that analysis. We don't get the ability to check if there's tumors at the edges. So it is my belief that we would have to treat the original volume. If the tumor is tiny and there's no disease in the original volume, then you have very wide margins, and that is good. But if we undertreated and only targeted the remaining tumor
Then
after
you have a
chemotherapy,
problem.
and if there actually is disease left elsewhere, not only do we not know about it, but we haven't treated it adequately. Certainly, hopefully that patient will get radiotherapy, but even with radiotherapy, if we left gross disease behind, it might not be enough to control it. So that's why I think treating the original volume is a better decision, better thing to do.
What is the best monitoring method after treatment? I was told no scans or blood draws, just wait for symptoms.
Yeah, it's kind of an unsettling thing that the data do not support aggressive screening and monitoring the patients who've been treated with breast cancer. I think the more appropriate answer is it depends on your original stage. That is, if you had an advanced stage, then you can make a stronger argument for looking more often. If you have early stage, there's less reason to look more often. But even in the more advanced stage patients, the data does not clearly demonstrate a benefit to close screening with scans and blood tests and so forth. So usually your doctors will, do an exam, hopefully they'll monitor your blood counts, and they'll ask for your symptoms. And if you're not having pain or not having abnormal labs, mostly they'll just delay the scans until there's a reason to do so, because when you compare groups of patients that had a lot of screening to those that had screening based on symptoms, the studies in general have not shown a survival advantage to those that had a lot of screening. They just had more procedures. They had more biopsies, they had more scans because things were seen. So they had more scans because things were seen. They had to follow up on those things. But their survival was essentially the same. That's why we take a more non-aggressive approach to screening.
Okay, I think we've kind of covered this one. Can you talk about the risk of reoccurrence with a lumpectomy with radiation versus a mastectomy with radiation?
Yes, so I think the lumpectomy for tumors that are less than 5 centimeters and node negative, the recurrence rate and the survival rate appear to be better in the patients that had lumpectomy and radiotherapy compared to those.
Okay. Never mind.
Compared to those that had mastectomy.
Okay.
We're talking about early stage patients. For patients with larger tumors, staged over 5 centimeters, are node positive disease, the evidence indicates that they have a higher risk of recurrence. We usually will pre-treat them with chemotherapy, and we'll usually recommend to them radiotherapy, even if they've had a mastectomy. They can choose a lumpectomy if they respond well. There's nothing to indicate that the lumpectomy is inferior. We just don't have the same data that's superior, because both groups are getting radiotherapy. The lumpectomy patient is getting radiotherapy. The mastectomy patient, if they start off with advanced disease, big tumors or positive nodes, they usually get radiotherapy as well. So both groups are getting radiotherapy. And so the advantage that lumpectomy might have is not there, but it also doesn't look like it's inferior. It's probably comparable. So we think take-home message is when radiotherapy is applied appropriately for triple-negative breast cancer, the outcome of lumpectomy is as good or better than the outcome of mastectomy.
Why is it recommended to do radiation after a double mastectomy?
It's not actually. So, if there's, the question is, what is the reason for double mastectomy? Now, for most, you can have double mastectomy because it's prophylactic, meaning you're a BRCA carrier, you're just having mastectomies, and the surgery is done to prevent you from developing breast cancer. There's no need for radiotherapy there. There's no cancer diagnosis there.
I don't understand why somebody would do that.
Right, and I'm hoping.
Why are you going to lop something off if there's not something there?
Well,
it may never happen.
Well, that's true. Now,
but I know some people are just scared.
There is a rule for prophylactic surgery, and for BRCA1 carriers, BRCA2 carriers, where your lifetime risk might be as high as 80%. When the question is a matter of when, not if, then for a young woman facing that risk and the need for the screening that needs to happen and the anxiety along the way, then the prophylactic surgery, to me, makes a lot of sense. As you get older, the risk, your lifetime risk goes down. It doesn't stay 80%. When you're 70, you still don't have an 80% lifetime risk
No.
of breast cancer. By then it may be as little as 10 or 20% because most of your life has passed. So then in that situation, we wouldn't recommend prophylactic surgery. So you have to think about the situation, but back to this question. So you do double mastectomy for prevention. Sometimes people have a cancer in one breast that either needs mastectomy or for which they opt for mastectomy, and they choose to have a mastectomy on the other side for one reason or another. Maybe they may choose it because they're concerned about the risk. They may choose it because they have anxiety about screening, even though the risk isn't there. They may choose it because they want to have symmetry. If they have reconstruction on one side or not, they may just want to have symmetry in their chest. So they may choose a double mastectomy in that sense. But in all those situations, the normal breast does not require radiotherapy. And a treated breast only requires it if indicated because of size or stage, big tumor, positive nodes, or skin involvement.
Is there an association between triple negative breast cancer and BRCA mutations? I guess you just.
Yes, 30% of BRCA carriers have rather 30% of people with triple negative breast cancer have a BRCA mutation. So if you have a triple negative diagnosis and you haven't been tested, you should. Does not matter what the family history is. Even if there's no family history, the triple negative diagnosis is sufficient reason to be tested. That's the first lesson. The second lesson that I mentioned earlier is that there are a class of drugs that are developed to target chemotherapy drugs, developed to target people that have mutation associated BRCA1, BRCA2 associated triple negative breast cancer. The drug produces better response and also better survival. So we want to know if a person has BRCA-related triple negative breast cancer because we want to actually change the chemotherapy regimen that they receive. So that's the other major reason for knowing.
Do women with triple negative breast cancer and a BRCA mutation require special treatment?
Well, that is
Yes,
the
that's
special treatment. That obviously, if someone has a BRCA mutation, there are lots of special treatment that they should get. They should have, testing to see if they if they have other associated like ovarian cancer testing, if they're BRCA1, BRCA2, because ovarian cancer may accompany is higher in those patients. They should have if they're triple negative and BRCA positive, as I mentioned already. There's a medication called Lynparza, which is a specific medication that's used for this population of patients. That drug should be offered to the patient as part of their overall regimen. Triple negative breast cancers also have a susceptibility to be treated with platinum-based chemotherapy regimen. It's something called carboplatin, for example, or cisplatin. And chemotherapy, those chemotherapies work better against triple negative breast cancers. So, as opposed to non-triple negative breast cancer. So that's something to know because it will affect how you treat it.
I would like to know why they can't come up with a maintenance drug for triple negative. Interesting.
So I guess the first answer is we haven't yet, but I don't think that we can't because I think we're learning some new things that will open some doors. What I've already described, this HER2-1 versus HER2 plus category. I mean, that's an opening for developing a maintenance therapy to target those triple negatives that aren't fully triple negative. We also have learned recently that there's another receptor that actually might be important. The data are developing. It's still being looked at in clinical trial, but about ER positive, PR positive, HER2 positive, where there's actually now another receptor called androgen receptor, AR, that we're now testing for because studies have shown that it actually might be present in as much as 40% or more patients with triple negative breast cancer. We might be talking about quadruple negative in the future for those people that don't have it, or they may be triple negative but AR positive. And for the people that are AR positive, there are drugs. These drugs are primarily have historically been used to manage prostate cancer because androgen receptor is important for prostate cancer in men. But those drugs are now being looked at in women with AR positive triple negative breast cancer because maybe we'll be able to provide a maintenance therapy targeting the androgen receptor, even though we can't target it ER/PR HER2. So there's obviously all of this is emerging in clinical trials and needs to be tested and proven, but there's some hope. And so we have at my hospital, this hospital, we have started to routinely test all patients for AR because clearly it's going to be potentially important for triple negatives, but it also might be important for some other breast cancers like HER2 positive or hormone receptor positive breast cancers that might not be responding to traditional therapy. This might provide another avenue to treat them.
Is it worth doing chemo if it's only partially effective and doesn't reduce the tumor or kill it?
There is a role. The typical way that we've treated breast cancer in the past was to do surgery and then treat with chemotherapy after. That approach is almost turn on its head when it comes to more aggressive breast cancers, because there's some things that we really need to know that are best understood when the tumor is still in place. If the tumor is in place and you treat it with chemotherapy first, and it responds brilliantly, that's very useful information. If it shrinks to nothing, it tells you that you're on the right drug, it's working, and it gives you prognostic information, like your outcome is likely going to be better. But also, if it shrinks, it makes surgery easier. We can do lumpectomy instead of mastectomy. It might downstage your lymph nodes from positive to negative, so we can do remove just one or two lymph nodes as opposed to all of them. So giving it up front has some really important advantages. Another thing that we may recognize is that if it doesn't respond completely, it will reveal that the drug that you gave is just not good enough. If you're given that drug after surgery, you would not have had a clue that it wouldn't have worked because the tumor would have already been gone and you would have been fine.
And so you're doing all this chemo for no reason.
Right, it might be completely useless. So giving the drug up front does allow for you to see the response and then change the regimen based on the response. And so the current approach that we've been using now for maybe 5 years based upon the study done a few years ago was for people that have an incomplete response, we add a medication that they get after surgery to capecitabine, Xeloda, because the studies showed that for people that were incomplete responders that still have residual tumor after chemotherapy, that their survival was improved when they added Xeloda after surgery. And that's just kind of one of them, I think, a number of things that will happen in the future, whereby we could either add more drugs before surgery or add additional drug after surgery. But giving it up front is very helpful to knowing how you need to adapt the therapy to get the best response.
What is the chance it will be only partially effective and there is residual cancer?
Well, there is a chance. We don't know that. Now, some people respond brilliantly, and some people respond in a very sluggish way, and occasionally some people don't respond. Not all triple negatives are the same. Even though we call them triple negatives, they're different subcategories of triple negative, and some are more responsive. They may be more responsive because they have a greater immune response. There's some subsets that have a very strong immune response, and so the presence of an immune response actually is an indication that the tumor is more likely to respond to chemotherapy. Because basically the chemotherapy unmasks some proteins which helps the immune system see the tumor, and so the response is better. That's kind of why the chemotherapy can help those tumors better. There's one subset of triple negative breast cancers that has a poor immune response. They don't respond very well to preoperative chemotherapy or chemotherapy at all. Now, they also might not need it as much, but the point is that the response can vary based upon the characteristics of the tumor. And so giving it up front can help you reveal that, what the response is and whether or not you need to do something differently.
Okay. Which types of chemo are they recommending and why?
Well, I think I went through a few of them. The basic chemotherapy regimen for triple negative breast cancer is ACT, Adriamycin, cyclophosphamide, and Taxol. That's the basic regimen that we've used over the years for triple negative, but that is modified based upon your unique characteristics. If you're PD-L1 positive, so we want to test to see if your tumor has PD-L1, that protein produced by the cancer cells to inhibit your immune response. If you're PD-L1 positive, then you want to add a medication like Keytruda because that medication improves the response. If you're BRCA mutation positive, then you want to add a medication like Lynparza because that improves response, and so forth. So there are medications that we add based upon your unique characteristics. And maybe there'll be an androgen receptor positive one in the future and so forth.
What is the benefit of receiving chemotherapy before surgery for TN? Well,
I think you know the answer now.
we covered that one. Can surgery be done if the cancer is spread to the chest wall?
Yeah, surgery can be done, but the first line of treatment is still the preoperative treatment. Chest wall it could be localized, so it'd be kind of a stage 3 breast cancer, or it could be stage 4 breast cancer where they're spread beyond the breast. It's important to understand what you're dealing with, but it's possible that you have simply stage 3 without distant disease. I just want to say, it's just an aside, amongst the unfortunate characteristics of triple negatives is that they have a high tendency to spread, and they tend to spread to the lung, the liver, and even the brain. And so you want to, at least for those patients, and this actually probably relates to an earlier question, we often routinely do brain scans as part of their staging workup because they may have, we want to detect an early brain metastasis. And of course, we do body scans because the lung and the liver are at risk. But if someone has chest wall involvement and doesn't have those things, then we treat them with the intent to cure them. That would start off with chemotherapy first to try to shrink it down to nothing, check the response, see if we have to change the medication based upon the response. And then ideally, if the area is resectable with surgery, we would remove it. And then irradiate the chest wall area, because even though the tumor might look like it's over here, when it involves the chest wall, it often spreads at the skin level or below the skin level in other parts of the chest. So we would give kind of comprehensive radiation to cover I assume the breast area, which is where where the breast cancer will appear. But I did want to share with you a side story, because this actually is, I told you earlier, I just went to make rounds on the patient, and I won't identify her, but I want to tell you the story about it because I think it really is very instructive on how well chemotherapy can work, especially for certain cancers. It's hers being, fortunately, one that was very responsive. She's
Was it triple negative?
Yeah, she's a young lady who had breast cancer that appeared in the axillary tail. This breast tissue normally goes to the armpit area, and so cancers can also develop there. And so hers developed in the axillary tail, and it grew to be quite large. And when she went to be evaluated, people offered her chemotherapy, but they also told her, you're going to need a mastectomy to manage this. And of course, she wasn't crazy about the chemotherapy question, nor was she, and she definitely wasn't crazy about losing her breast. And so she sort of delayed the process. When I saw her 6 months ago, she had a tumor in the armpit that was about that big.
Oh my God.
She could not lower her arm.
It must have looked like a goiter or something.
It was like a basketball sitting in her armpit. And obviously she was dealing with this new challenge. It was ulcerating, it was draining, it was painful. She had arm swelling. She had all of these challenges. And, she was okay with going forward with therapy, finally, chemotherapy, but she did not want to lose her breast.
Wow.
So I somehow convinced her to try, that would commit to her. If we could save her breast, we would save her breast. I was just dependent upon how well she responded to chemotherapy. So she was seen by one of the oncologists here. He started on the chemotherapy regimen, and this thing just started to melt away.
Wow.
It was like rotting. So it's actually the first case in my 20-year career where I had to take the patient to surgery during chemotherapy to clean away dead tumor. because it
Wow.
was getting kind of unpleasant.
Oh, yeah.
So you almost like scrape it away. And then she continued more chemotherapy, and then the next part melted away, and that's scraped it away. I didn't literally scrape it away,
Yeah,
but it was
I know.
essentially, it was very,
It's
it was
gnarly.
just it was just a dead material. It didn't have much integrity to it. And so she finished the entire chemotherapy course. When I saw her last in office, she had the contour of exo looked like mine.
So
The
everything
tumor
would
was
look
gone.
normal again.
It just looked like a scar. Like
Mhm.
the residual base of it was a scar. Now, in the case of even this kind of dramatic response, it's still appropriate to remove the remnant just to make sure that they're not residual cells there. And so yesterday, we did a procedure where I resected the lymph nodes and the skin and the remnant area. She had a flat reconstruction of that area, and I checked on her early. She's doing great. And I said, I delivered my promise of preserving your breast, which, unfortunately I was able to do. But it's just an amazing story that, she had such a dramatic response, and it kind of inspires us to take on, because I could have seen how she would have been turned away by many people, and how she would have been discouraged by, her interactions. But fortunately, she trusted us enough, and the drugs worked well enough that we were able to really achieve a great outcome for her.
Wow.
I would not be surprised if there's no cancer left in the specimen. That's what I'm expecting, because she really did respond brilliantly.
That's awesome.
Mhm.
Why isn't there a scale for TNBC equivalent to the oncotype
Yes.
stores?
So there may be one day, but it would be for a different purpose. The oncotype test that was mentioned is an oncotype test that was developed for people with hormone receptor positive tumors. By hormone receptor positive, I mean ER positive or PR positive. So if it's a hormone receptor positive tumors, then the question for them is, yes, we know they need anti-estrogen therapy, but do they also need chemotherapy? And so the oncotype test was developed to answer that question. Do you need chemotherapy in addition to anti-estrogen therapy? For triple negative breast cancer patients, essentially all of them get chemotherapy. So there's not really a question. They're not a candidate for anti-estrogen therapy, and almost all of them are treated with chemotherapy because it's really the only two we have to attack them. The ones we don't treat are the ones that are basically less than a centimeter. And even then, if it's in a young woman, we'll probably recommend chemotherapy because we don't have another way to control it. We don't have the AR receptor understanding worked out yet. In HER2, the therapy for the HER2 1 or 2+, it really was only studied for people with advanced cancer, not early stage cancer. So for these smaller tumors, we don't really have another option. We either do nothing and observe, or we offer chemotherapy. But the point is, in response to this, is that for triple negative breast cancer, it's either do nothing for the very tiny ones or treat with chemotherapy. So the oncotype doesn't have a role for this population of patients. Now, maybe one day there may be a test to help us better understand which chemotherapy drugs we use for one group or another. But I think that for the foreseeable future, chemotherapy will always be a part of the treatment for triple negatives because of their high likelihood of growth and spread and high risk of death because of that.
I'm not sure about this question. It says, would you consider a weak hormone score as TN, such as ER8, PR0, and HER2 negative?
So I'm going to simplify it. So when we say that you are ER positive and you're PR positive, it's nuanced, meaning that technically speaking, according to the standard way that we measure it from the lab, if you have less than 1% of your cells, like when they look under the microscope and they're looking for cells that let me step back a moment. To assess the receptor status of a tumor, they stain it with antibodies that attach to the cells that have estrogen receptor or progesterone receptor HER2/neu. If they all stain, like if the antibody attaches to all the cells, then we'll say your estrogen receptor expression is 100% because 100% of the cells have bound the antibody. On the other hand, if less than 1% of the cells bind the antibody. So out of 100 cells, only one of them stains positive. We would say that your estrogen receptor expression is 1%. Now, most lab tests report negative as less than 1%. Anything 1% or more is considered positive. Now, you can probably get an idea that 1 is not the same as 100, but still, there's some expression, so that's considered positive. So even if you have an estrogen receptor level of 8, you're considered positive, even though it's not the same as someone who might have estrogen receptor expression of 80, where they would be logically more responsive to anti-estrogen therapy. The same principle applies to progesterone. We score them from 0 to 100%. If it's less than 1%, it's negative. If it's 1% or more, it's considered positive. Now that's the most accurate answer to the question, but there's a nuance. When drugs are tested against triple negative breast cancer, they use a different scale. They don't use less than 1% as negative for ER and PR. They actually use a scale that's less than 10%. So even if you're technically negative, like you're in the trials are more generous. So you can qualify for triple negative trial, even though you have a little bit of ER, a little bit of PR, 5%, a little bit of HER2 neu. This patient who you described as having ER 8%, PR 0%, HER2 negative, she would technically qualify for triple negative trial, even though by the purest definition, she's not triple negative. But the trials use a different threshold to expand the number of people who would be eligible for it. Because even though has ER of 8%, I mean, she has 92% ER negative.
Right.
So she could potentially still benefit from something that targets a patient that has no estrogen receptor expression.
What is the residual cancer burden and why is it important?
Well, the take-home message from that is one that we've already kind of addressed, which is that when you get chemotherapy up front and you respond brilliantly, that there's no tumor left, like the patient I described, then your residual remaining cancer burden is low. It means that you responded well to treatment and your prognosis is good, and there's less of a need for you to have additional therapy after. If you get chemotherapy up front and you only partially respond, and you have a lot of residual cancer left, then your residual cancer burden is high. It suggests you were a poor responder or not a great responder, that you do need additional therapy, and it also indicates your prognosis is not as good because of that. So many people will record the residual cancer burden as kind of a number to kind of assess where you are. But basically what we're looking for is how much tumor is left compared to what was there before. What does it signify in terms of how well you responded to treatment and what you might need to get a better response?
What can we do to decrease the risk of recurrence? Any diet or exercise specifics?
Yes and no. I mean, obviously, the most important thing you can do to reduce the risk of recurrence is to complete comprehensive therapy. That is appropriate surgery with the negative margins, radiotherapy based upon tumor size, stage, and the use of chemotherapy, plus other agents, because that's what the evidence shows is associated with the lowest risk of recurrence. But there's some other information out there that's a little less clear about lifestyle things. One thing that in that category, the thing that is most clear is that, exercise and maintaining lean body mass is beneficial. Maybe it's because it's mediated through the insulin-like growth factor we talked about earlier, but having a lean in body weight and exercising is associated with a lower risk of cancer recurrence for both hormone sensitive breast cancers as well as for triple negatives. That's what I can say. Beyond that, I don't really have data regarding supplements that might be beneficial.
Or diet.
But again, the diet is, you only get to have a lean body mass if you're being attentive to what you're eating and drinking. So diets that are rich in fruits and vegetables, that's poor in processed sugars, and supported by exercise, that tends to have the best prognosis from a cancer control perspective, as well as for diabetes and hypertension and the other things that we die from.
When there's lymph node involvement, what determines how many lymph nodes you remove?
So this is a place of evolution. Traditionally, when someone had a positive node, we removed all nodes. That was the standard of care. We did a sentinel node, but at one point, at the very beginning, we just removed all the nodes. I won't say we, it was before I started practicing more than 20 years ago, where the nodes were removed just because they were there and the way to figure out if they were involved was to take them all out to check them.
And if it's too late, you can't put them back.
You can't put them back. And then, just before I started practicing 20 years ago, there was the sentinel node biopsy technique that was developed whereby we could use this process of testing the first or second node to see if they're involved. If they're clear, it gave us confidence that the others were clear, so we didn't have to remove them. But at that point, the protocol was if the sentinel node was positive, then that indicates you do have lymph node involvement, and we would recommend removal of the rest. So we do still recommend removal of the rest, but only in those patients with proven positive nodes, as opposed to those people who simply had nodes, whether or not they were positive or not. So that was the sort of protocol for most of the last 20 years. But the last 5 years, we're becoming even more conservative or even more deliberate about how we manage the lymph nodes, because we know from trials that in many ways radiation can compensate for can treat lymph nodes as well as surgery, especially when they're not grossly involved. And the complications of radiation of the nodes is less than the complications of surgery of the nodes. So increasingly, we're at the point where if you have a positive node from your lymph node biopsy, but your remaining nodes look normal, they might be microscopically involved, but they look normal, then it's reasonable to extend the field of radiation to cover the lymph nodes without removing those lymph nodes surgically. I think increasingly that will be the way of the future. Certainly some of those patients will have lymph node recurrences, but there probably will be a minority of those patients. Those patients can go back to surgery to have those lymph nodes removed, but the rest of the patients whose lymph nodes are controllable enough by radiation can be spared the burden of surgery. Because when you combine both extensive surgery and radiation, the complications of lymphedema go up dramatically. We're trying to take out the surgery complications, and those that get radiation alone have a much lower rate of lymphedema, so the quality of life is much better.
Can cryoablation be used in the treatment of TNBC?
I think the answer is yes. Certainly I've used it. But it's more complicated than that because, cryoablation only replaces the lumpectomy part of the operation. It doesn't replace the other parts of the treatment. And one of the biggest challenges is getting the patients to embrace the importance of chemotherapy and to embrace the importance of radiotherapy for those patients. Now, certainly women have the freedom to choose the treatments that they want and amongst the things that are available to us. But they also have to recognize that there's trade-off. And if they decide, well, I want to avoid radiation because of one reason or avoid chemotherapy, the trade-off is that they may be accepting a higher risk of recurrence or compromised survival. And that's a decision someone can make, but they need to be clear that that is a decision that they're making. Cryoablation does not replace the need for radiation. It does not replace the need for chemotherapy. And all the data for triple-negative breast cancer show that, certainly for people with tumors over a centimeter, that chemotherapy is important. And if they're treated with breast conservation, the survival data are clearly better when radiation is added. So it can be used, but it's just part of a comprehensive treatment. It's not.
It doesn't replace it. What are the recommendations for scans, blood tests, etc., for after the treatment? It seems that protocols for what to do to monitor for reoccurrence are all over the place with no consistency.
Right, so we addressed this earlier, I think, but I'll just emphasize a couple of points. There's no standard protocol. Well, the standard protocol is to not do extensive. Right. It is, but I think there's some nuance because life is nuanced. We know that triple-negative breast cancers have a higher risk of spread to organs, have a higher risk of spread to the brain. So, the threshold for checking those areas should be lower for a tumor that's more likely to recur. The pattern of triple-negative cancers is also different. Triple-negative cancers, when they recur, if they recur, tend to occur in the first or second year. Hormone receptor positive breast cancers tend to occur year 3, 4, 5. There's a little bit of a lag phase. So if you're going to look, it's important to look more frequently early for triple negatives, whereas for hormone receptor positives, you seem to look early, but you can wait to the third year. Now, this is all hypothetical. This protocol is still not to look very aggressively, but if you're trying to sort of communicate with your doctor about your anxieties about looking, you should recognize that delaying the process for triple negatives might not be as good because these tumors are more likely to come back fast, and you want to find them fast. And so, I mean, if you because that's when you might best be able to manage it. So the general rule is, we don't do body scans and we only do lab works and we ask for exams. But for triple negatives, it might make a little bit more sense. This is just my feeling to do scans earlier.
Can you do just ultrasound, or do you need more than ultrasound for triple negative?
The question is, what are you looking at? So you're talking about breast scans or body scans? And I'm actually
Breast scans. I was thinking, okay, you're talking about. Okay.
I'm thinking about body scans. Now, certainly for breast scans, we still would routinely recommend annual imaging. There's not really a need to screen twice a year, although you can. There's very little harm in screening twice a year. It's really the body scans that sorry, wasn't clear.
Which that would be a PET scan?
PET scan, CAT scan, bone scan. Those scans, and basically the studies for those scans show that, screening every 6 months or yearly routinely didn't produce better results than those that got screened based upon whether or not they develop symptoms. It just didn't improve their survival. And I said before, they just got, we all have lumps and bumps inside that we don't know about that never become an issue. But once we see them, now we're anxious about them. Now we have to recheck them in 3 months or 6 months because maybe it's cancer.
And anxiety doesn't help.
Maybe we get biopsies of them because we worry.
It just opens a can of worms you don't need.
Right. And so there are a lot more procedures. Some are harm related to those procedures. And no, statistically, maybe in an individual patient, but at the population level, no improvement in the outcome of those that got frequent screening to those that got symptom-based screening. So that's why it doesn't make sense, but that's why, it doesn't emotionally make sense, but that's why most doctors still say we don't need to do aggressive screening because it doesn't make sense. Now, the other part of the story that is more painful is that finding early might not make a difference in the outcome.
So you might have been better off not knowing because you would have enjoyed your life better.
Maybe. Given the limited tools that we have, especially for triple negatives, the limited tools that really, really work well, that finding early, this month versus 5 months from now might not make a difference in your outcome. The drugs may not work as well, or they may not work. And you just would have gotten earlier treatment, but the same outcome.
Do you believe triple negative breast cancer can be healed?
Well, I think healed is I'm not quite sure what healed means. I think it can be cured. Yes. I think it's harder to cure than the others, but there are definitely people that have had cures, and the ones that have the best prognosis are the ones that have the best response to chemotherapy. And we determine that by doing the preoperative chemotherapy. So that's why the default thing for triple negatives is to do chemotherapy up front for people with tumors over 2 centimeters and people that have no positive disease. Because we can learn a lot about how to manage them, but we also get a clue for the ability to cure them. So yeah, I think it is curable, but it requires comprehensive care.
Do you believe that surgery can always make the situation worse? Can also make the situation worse?
Well, if you rob yourself of information, that may be helpful. It doesn't always, but I did give the example of someone who said you may insist on surgery first, but maybe because they don't want to have chemotherapy, or they just want to have surgery before they have chemotherapy. We try to talk them down from that, particularly for triple negatives, but sometimes, it's the only way you can move forward. That's a situation where removal of the tumor will remove the opportunity to understand how the tumor responds to the drug. and they might end up getting a suboptimal therapy or an incomplete therapy because we didn't get to witness whether or not the tumor was a responder or not to the drugs.
Not sure if that was the way they meant the question, or if they're just talking to, some people think surgery can make it worse. Because you're cutting into it and maybe it can spread, maybe, but.
Well, I mean, there's, there is in the history of breast cancer, as best as I can recall the data, there's never been a situation where non-operative therapy was better than operative therapy. When managing it without surgery was better than managing it with surgery. So there's no proof that that is true. Now, how you do the surgery can impact it. I mean, our goal, especially when we pre-treat it, is to shrink it down to as small as possible so we can have, wider margins and better results. Some people express concerns about biopsies and whether biopsies contribute to spread, but we can only do chemotherapy if we have a biopsy up front. So we definitely need it for those patients. But I think that's, given what you're dealing with, that's an acceptable risk. Because if chemotherapy is effective, it's going to deal with whatever. If chemotherapy is not effective, then they have worse problems than the needle biopsy.
Should the approach be holistic and looking for underlying issues?
Well, it should always be that if they're identifiable. I mean, there are underlying issues that you can identify, lifestyle issues that can be emotional issues. Yes. It's part of the overall treatment. It's not a substitute for standard therapy, but if underlying issues gave rise to the cancer, they can also contribute to recurrence, and they are also a greater chance of contributing to other health conditions as well.
I think they're probably thinking of doctors that just treat the cancer and don't recommend you do other things. Like it's kind of a holistic thing, like you need to treat your emotions and you need to treat your diet and you need to treat the whole terrain to get the best outcome.
And our Western system isn't really set up to do that
exactly
well. I mean, but it doesn't mean it's not important. And so patients really kind of have to, unfortunately, advocate for themselves. We can help them. It's just that in most centers aren't set up to address all of those. We have some resources here, but we're not committed to that comprehensive management.
And I guess the comment is that we need to be more that way.
I agree with you. And so, I work collaboratively with naturopaths because I do think there's more to the story than just the drugs and the surgery, that they are complementary, not truly alternative. And so my feeling is always emphasize complement means two things working together as opposed to one thing is substituting the other. In that,
you mean like me doing all the holistic and giving in and doing the Herceptin as well?
I won't say giving in.
I think I didn't want to do it,
deciding.
But after I researched it, it seemed like I didn't have a choice.
I mean, there are lots of things that we do in life that we don't want to do, but we do it because it's part of a way of facilitating life.
Well, once I saw the whole picture and I watched Living Proof and saw the point of all of it, it seemed like a no-brainer. I kind of had to do it. If TNBC reoccurs, what are the typical signs of that?
Well, it depends on where. So you can have a local recurrence in the breast. So you can have an abnormal imaging study because you put the screen, or you can have a lump that develops generally in the same region of the breast where the original cancer is present. Or you can have a lymph node that develops that can be detected on ultrasound or by exam. That's typically what you see when you have a local recurrence, one of those things. The other thing is that you might have an abnormal lab, like if you have your liver function studies become abnormal because you have a liver metastasis, then that's something that can be detected. Pain in the bone, although triple negatives hormone positives are more likely to go to the bone than triple negatives, but triple negatives can go to the bone. And so having local pain in an area that wasn't previously a bother, that could be a sign. Of course, there's always this brain issue stuff, the potential for it to metastasize to the brain can cause some loss of function or some other neurological injury. Those are the things you would look for that we would inquire about, but hopefully you're going to find. We don't do routine scans, as I said, so it's not like these things are going to be found just because we're doing annual CAT scans or PET scans. You might be able to discuss with your oncologist whether or not he she thinks it is beneficial. Like if you're advanced stage, maybe you can make a strong argument for that. But in general, it's going to be based on symptoms or routine breast imaging.
This is an interesting question because it kind of doesn't make sense. It says, why is it not necessary to have scans between chemo and surgery? But wouldn't you want to have a scan to find out if it shrinks?
So it's strangely worded, but
Yeah.
generally speaking, we do scans between chemo and surgery. This usual protocol is that you want to have a complete set of imaging studies before you start.
Right.
So I'm talking about the breast imaging.
Right.
So whether it's mammogram, ultrasound, ideally MRI as well, to understand the full extent of disease. The patient then undergoes preoperative chemotherapy. We call it neoadjuvant chemotherapy as well. And then at the end of that therapy, before surgery, we repeat the imaging studies. Repeating the imaging studies gives us very useful information. We get to assess response. We get to assess the residual cancer burden. We get to determine if the patient has had a clinical complete response, which means that there's no longer any visible tumor in the breast by imaging studies. That's a clinical complete response. It's a very good sign.
If you have that, would you still have a surgery?
You do. And in fact, the patient that I operated on yesterday had a complete clinical response. We didn't have proof that she had residual disease, but we have to remove at least some part of the original tumors to prove that.
Okay.
And there are people that actually do have some microscopic diseases that needs to be treated, and that tells us they had a really great response, but an incomplete response, and they need more therapy. So we want to at least see if there's anything surviving. We actually do make treatment decisions where if they don't have any residual disease, we don't add therapy. If they do, we do add therapy. So it's a decision tree that we get from removing tissue. But so those scans are really important. Obviously, if they have a bigger tumor and a smaller tumor, then the scans will help the surgeon to think about lumpectomy, adjust the extent of surgery so that they can have a smaller lumpectomy, or determine if lymph nodes are positive before. If they now look negative, we'll do a sentinel node biopsy as opposed to a complete lymph node removal, as you would have done at the beginning of the process. So it's crucial to have those scans done.
What does the B indicate in a stage 1B?
Oh, yes. So the B usually indicates nodal involvement. Like when there's stage, there's 2A and 2B. 2A means that you have a tumor between 2 centimeters and 5 centimeters, but the lymph nodes are negative. 2B means you have a tumor within that size range and the lymph nodes positive.
Okay.
So for 1B, stage 1 means the lymph node is completely negative. Stage 1B means you have a micrometastasis. So it's a little bit of positive, but not really strong enough to be a stage 2 breast cancer.
So what do you do with it?
We manage it with lymph node biopsy, sentinel node biopsy, and radiation.
Okay.
We don't usually recommend chemotherapy for micrometastasis in the node, but it needs to be managed in some way. Removal of that node and irradiation of the rest is sufficient for those patients.
Is loss of heterogeneity, okay, you can pronounce it.
Loss of heterozygosity, hereditary. I forgot that question was in there, because there's another question about it. If you have loss of heterozygosity, do you have a greater risk of recurrence? So basically, heterozygosity means that you have more mutations. So more mutations and changes in your chromosome count, because they're mutations, the more primitive, the more aggressive the cancer is, the higher risk of recurrence, the higher risk of spread. So it's not a favorable thing to have. The more loss of heterozygosity, the worse the tumor behaves. We don't routinely measure that. It's not one of those, it's not ER, PR, HER2. We don't measure that in those panels. But it is something that can be assessed. But it doesn't guide treatment. There are other things that guide treatment. That's not one of the things we use to guide treatment. So it's kind of informational, but not actionable.
What can we take or do to get the most effect from the radiation, also to protect the healthy cells during radiation? So
talking about radiation after lumpectomy or mastectomy, I mean, the main things are to care for the skin well, to keep it wash, to wash with, with warm water. Don't use things that are caustic. Don't apply ice or heat to it because the skin might not be able to tolerate it. Keep it moisturized with water-based agents, not alcohol-based, because alcohol-based
Dries.
moisturizers are drying. So you want to use something that's aqueous, like aloe vera, for example. There are some hydrocortisone. If you're having skin reaction, we call it desquamation, where you have some peeling. Hydrocortisone cream can be applied. You should do that under the advice of your provider. You shouldn't do it on your own, but you should ask for their advice on how to treat it. And then there's also there actually is a medication that has been looked at in clinical trials to reduce the radiation injury from radiation to the skin as part of breast radiotherapy. It's called amifostine. So you can ask your provider if it's appropriate to consider that.
What is the percentage overall of reoccurrence?
It's not a simple answer because it just depends on stage. Depends on stage, like whether or not your tumor only involves the breast or lymph nodes, whether it involves another part of the body. It depends on whether or not you're a good responder or a poor responder. So I don't have an answer to the question, but I at least want to give you the context in which you can think about it. So if you responded greatly and there was minimal residual disease left in the breast, then that's an indication that you're likely to be in a low risk group, less than 10% in the next 5 years. If you were a poor responder, then you likely will be in a higher risk group. The thing about triple negative is that you usually get the answer in 3 years. Because if you haven't recurred in 3 years, then your recurrence rate looks as good as people that have hormone receptor positive breast cancers. Doesn't mean you don't recur, but you have infrequent recurrences over time. Is that 3 year? So same things for HER2 positive breast cancers. If you get through the first 3 years without a recurrence, then it looks great.
I got 1 more year.
Yes. But they can recur quite early, and it's not that it came back. It's just that there was some left behind that just wasn't clear about the treatment, and it regrew.
Mm-hmm. What is the pattern of reoccurrence after treatment for TNBC?
Well, breast cancers tend to recur locally, meaning they occur in the same quadrant of the breast that was affected. So that's called a local recurrence. It's reduced with radiation. It's reduced with adequate surgery with clear margins. And you can have axillary recurrence, particularly if you were node positive before. You could have recurrences in lymph node. And then there's this distal recurrence, which I mentioned, bone, lung, brain. So let me say bone, brain, lung, liver being the most common ones for triple negative, although it can go other places as well, but those are the most common ones.
Is breast tenderness common for a long period after radiation for TNBC? Well, radiation for any of them.
Yes, radiation for anything. The radiation ends, but the effects last for a while as the healing and post-radiation changes continue to develop. So, 6-12 months, even longer, you can still have breast tenderness and breast changes as you recover from the radiation that you received a year ago.
Are there any other variants besides BRCA being studied or known to cause this type of breast cancer?
I'm not aware of any, but that doesn't mean that there aren't any, and it doesn't mean that perhaps someone else knows. But the key ones are BRCA1 and BRCA2 as being associated with triple negative. I think there may be PALB2, PLB2 might be a third as well. But the guidelines that we currently use for BRCA testing specify specifically an indication for BRCA testing in patients with triple negative breast cancer. And it's for testing for BRCA1 and BRCA2. So those are the ones which we have the clearest association.
If you have a reoccurrence relatively soon after finishing treatments, do you have an even higher risk of it coming back a third time, recurrence on the same side as mastectomy 4 months post last treatment?
Yeah, unfortunately, that is the answer. That if someone has an early recurrence, it's an early recurrence because it was disease that was left behind, and that was not cleared by whatever was done, whatever the treatments, had been provided. So they had surgery with disease left behind in the breast because maybe it just wasn't detectable at the time, or they had chemotherapy and it killed most of it, but left some remnant cells behind, and those regrew. So, it indicates kind of an incompletely treated cancer or a resistant type of breast cancer. And that suggests, and usually the best round of treatment is the first round of treatment. And the most effective regimen is the one we give first. So second line and third line treatments are second line and third lines because they're not as good as first line. So it becomes a little more challenging to treat effectively the more recurrences you get.
What can we do to prevent it from returning? And are the chances for recurrence determined by what stage you were in?
I answered that question, and the answer is a few minutes earlier in the presentation. Just rewind.
I'm a 69-year-old senior just diagnosed with triple negative breast cancer, stage 3-4. I need state-of-the-art treatments. My cancer is inherited, so I need targeted gene therapy, immunotherapy, or DNA type. Do you know of anyone anywhere in Connecticut you can get that kind of treatment?
Let me see the question again. So I think this is a great one to wrap up with because it touches on many things. So first of all, most medical oncologists in the country are familiar with treating triple negative breast cancers. So I think, there are lots of places you can go, and I don't know anyone in Connecticut, but I'm pretty confident you can find someone in Connecticut who can do this because the protocols are pretty standard. The protocols are mostly defined by or at least recommended by the National Comprehensive Cancer Network, NCCN. So you can find them on your own, online. And it says, patients need a certain kind of therapy. She's stage 3 or stage 4. So she needs to have preoperative chemotherapy, or preoperative meaning chemotherapy before surgery for stage 3. For stage 4, we don't necessarily consider preoperative because surgery may not be offered for stage 4. But in either case, treatment starts with chemotherapy first. She's mentioned she is a gene. She's triple negative. Well, I'll just ask a question. The gene therapy that is needed is not necessarily gene therapy, but it's understanding if she's a BRCA carrier. So she needs BRCA testing, because if she's BRCA positive, then there is a drug for BRCA carriers that she should be treated with. And most medical oncologists know, all medical oncologists know this if they treat breast cancer. So that's something that she should say. She hasn't had genetic testing, it should be done because that's important. Immunotherapy is something that's a consideration for triple negative patients. They should test their tumor to see if it expresses PD-L1. That's that protein produced by cancer cells that inhibit the immune response. If she's PD-L1 positive, then she would be a candidate for Keytruda, for example. So that's something that she should ask her oncologist about. Am I PD-L1 positive or not? Have you tested? If she tested, that'll answer the question. For patients that are PD-L1 negative, especially stage 4 patients, there's some trials looking at treatments for them as well, immunotherapy treatments for them as well. So just because she's PD-L1 negative doesn't mean there's no option, just that those options are available in clinical trials.
So it's always worth researching a clinical trial too.
Right. And so again, if she's being seen by a medical oncologist who specializes in breast cancer treatment, likely they're utilizing clinical trials. And so that's something to ask. You can ask, if you don't have it, is there another place I can go that has it? So she doesn't only have to go to that place in Connecticut if that's the case. But I think there's some unanswered questions in this question, but there's some important things that she needs to consider. Genetic testing, PD-L1, whether or not she has either of those factors that can be used to help her. Clinical trials, if none of those are present for her, the options for clinical trials are still there, because there are lots of new drugs that are in the pipeline looking at different ways to target triple negative. And we can only learn if they work if people participate in trials.
I have a question.
Yes.
What's the likelihood if you get breast cancer on one side that you'll get it in the second side? I had a neighbor who had it in one side and then 5 years later got it in the other side. She said it wasn't the same cancer. I don't know what she got, so I don't know the specifics. But is it likely if you've had it on one side that you might get it on the other side at a later date?
It's actually the opposite. It's unlikely. It doesn't mean that,
okay.
and that it can't happen, but if you look sort of, if you take out the category of people that have mutations, so one question is she mutation?
Well,
So if you take them out of the formula and you look at the non-mutation carriers, the average patient with sporadic breast cancer, over a 20-year period, the chances of getting breast cancer in the other breast is about 5%. Now, one reason that it's about 5% is that the treatment you get for the cancer breast has a benefit. Like if you're on anti-estrogen therapy for 5 years for your life breast cancer,
or if you did
Herceptin, then the other breasts will receive some of the benefit of that, and that will suppress cancer growth. So that's why we generally feel very confident to say you don't need to do anything or worry about your other breasts. In fact, the chances of you having cancer in the treated breast is higher than you having cancer
in the non-treated
breast, right? I mean, what I'm saying, the chance of you having a recurrence in the treated breast is higher than the chances of having a recurrence in the normal breast. So that's why we now you could have a different kind of cancer. So maybe cancer in one breast is hormone receptor positive, the cancer in the other breast is triple negative, so it would not necessarily benefit from.
Maybe that's what happened. I don't actually know.
But statistically, it's still 5% of people we're talking about that actually do have that cancer. And in fact, what we also see is when we routinely perform, like when we do prophylactic mastectomies, like, take off this breast and take off the other breast, take off this breast for cancer, but remove this breast because you either just want to do prophylaxis or you want to do it for symmetry or whatever. We have about a 3 to 5% chance of having cancer found in that breast that was removed prophylactically. So it actually aligns pretty closely with the frequency of finding cancer that develops in that breast over that 20-year period. So it's perfectly fine to leave your other breast intact, unless there's no reason not to do so. So we covered a lot.
Yeah.
And this very complicated.
Seem to always get through all the questions.
Topic. Yeah, and this is a tough one because it is obviously a scary one.
This is actually the one that I knew the least about.
Yes, and although all the others have a lot of effective therapies, multiple strategies, this one is sort of the one that is the hardest to treat. There are lots of things that are emerging, but not as much that's well developed and improved. And no adjuvant therapy, no maintenance therapy yet, but I think that'll change. This is triple negative breast cancer. We'll choose with your assistance another topic for the next one to take place in October. But I withdraw the time and thank you for joining me again.
Thank you for answering all their questions. I'm sure they were very happy about it.
I'm trying, but you have your own providers, so this is just food for thought to equip you to have a more informed conversation with your providers.
The more knowledge is power, the more you know to ask questions, and the more you can find out.
That's our goal. Thank you very much. Thank you very much. Have a great day.